extending the time, so it means I can speak shorter. I'd like to thank everyone for coming tonight and to listen to maybe the Irish side, where we have international speakers, that you can see what is happening in Ireland with regards, particularly with needle exchange, which in community pharmacies we talked about, I think, for a decade at this stage, and has finally started to happen in, albeit not as many locations as what we'd like, but it is increasing as we speak. We currently have 49 pharmacies around the country involved with needle exchange, and that's hoped to increase up to 82 by the end of July. So it is a continuum of building up pharmacies throughout the country to be involved in it. The body of evidence out there is very clear that if you have access to clean works, clean needles, that you reduce the risk of blood-borne viruses and shared needles, and they have access to clean injecting equipment, which is not only the injectable paraphernalia itself, but citric acid, water for injection, and also swabs and tourniquets. We also have it as an action of our national drug strategy, which highlights the need to expand availability, which is quite clear of needle exchange services where needed, which hasn't been documented whether it be pharmacy or static or peripatetic, but a whole plethora of these is what's really required rather than just one standalone type. Currently, this is what our fixed needle exchange sites look like around the country. That's all of them. Outside of that, there's one in Limerick. It sits for 2 hours on a Thursday. That's currently the current status. If we then look at our backpacking or peripatetic, we'll see up in the northeast, there is a peripatetic service offered by the Anna Liffey project and Merchant Ski in the Midlands, along with our own HSE statutory services. As you can see, one outreach worker cannot cover a whole county. They're asked to provide a syringe or needle exchange, so we're in the county, be on one side, to travel to the other side of the county. So then it was decided to look at from the health atlas in Ireland of where the proposed sites should be. The proposed sites were just scattered throughout the country in various locations where it was deemed that there may be a need or a want because of perhaps people waiting to come onto opioid treatment, that people are accessing needles through voluntary and statutory services outside of their local area. All these areas were targeted for training, and as of September we had the yellow dots and the waiting training are the red dots, which is hoped to be completed by the end of next month. And in that there should be a location in every county, at least in every main town, of at least one pharmacy that's providing needle exchange. In some locations, for example in Limerick, Waterford and Cork, there's more than one pharmacy currently providing needle exchange. Why community pharmacy? Well, I'm a pharmacist, I can't help myself. I just want community pharmacists more involved in this. Some people would say I'm quite aspirational about where the community pharmacists should be with regards to their role and remit. But we know that from a logistics perspective, they're scattered throughout the country, they're accessible, they're open, they have a professional person involved who can undergo training in order to be able to participate in providing appropriate information to service users when they attend to look for a needle exchange. And in direct line with that, it was decided through our teaching college, which was formerly the ICCPE, now the Institute of Pharmacy, to look towards having pharmacists do training before actually participating, so that everyone had a similar standard before coming on board. And in the training area, which was developed in conjunction with the Irish Pharmaceutical Union, the Pharmaceutical Society of Ireland, it was decided that a number of areas should be looked at. This is also done in conjunction with both the voluntary and statutory services that currently provide needle exchange, and wondering what levels that pharmacy could interface at. Issues that came up were ethical issues, what to do with under 18 on a methadone programme. Overdose prevention was discussed and looked at, and a piece of training provided on that. And obviously the confidentiality, respect and courtesy, and attitudes of pharmacists towards service users coming in. Practical issues, simple things like Hep B vaccination, the how to do it, the recording process, standard operating procedures, which pharmacists in the audience know that the bane of our lives currently in order to be compliant with legislation, and then storage disposal of waste, and then specifics of needle use and what drugs are injected. My usual line is all drugs, or anything you like. What are acidifiers for? Because some pharmacists at the training would point out that it says you're not supposed to use this for injecting. It says clearly it could cause vein damage, so you have to go through the whole risk, the whole thing around harm minimization, prevention of harm to the individuals, and then the routes of injection. I should also say that there are people in the audience who actually have done the training, so they can criticise and actually currently participating in the programme, so they can criticise how badly the programme is currently being run, or how well the programme is being run. During our process, we developed a leaflet, which the first leaflet we did was a beautiful red leaflet, danger, red, which we decided was maybe not the best after consultation with the Service Users Forum up in the North East, through the Anna Liffey project, and also through jurisdictions in the UK and the Irish Legal Exchange Forum, that it might be better to tone it down a small bit, take out a lot of the information, and look at how to provide an information to someone who needs to know how to use this one-hit kit, which is a very specific type of device, versus needles that we currently have in this country. As you can see, that the one-hit kit is a contained syringe and filter unit. It's all self-contained, it's not a separate filter to a syringe and needle. And also, there's a unique identifier in the barrel that service users can identify their own needle by scraping off various combinations of ABC, 1, 2, 3. So that's the leaflet that's gone out to community pharmacy, and I'd like to thank all those who've participated in its development. And that's what the pack looks like in a community pharmacy, so it's all self-contained in one unit. And within the unit there are 10 one-hit kits, 10 water for injection. There is a leaflet, there is a personal sin bin, and in each community pharmacy this is handed out to a patient. And you might ask the question, when they return in the pack, the answer is not necessarily, depending on the individual that's presenting and how they present it themselves. That's a one-hit kit. There's the needle, syringe, and filter all as one. There's a little filter spoon and cup, and then there's alcohol pre-swap and citric acid also included. This is all contained within its own self-contained packet. And the idea around this was that all injection equipment is contained. So if a service user decides to appear and exchange, that they actually can just pull it out without actually having to root around in the bag and have an accidental damage to the needles, hurt themselves. It also highlights for us, for service users and for everyone involved in the scheme, the potential role of the spoons as vectors for the transmission of bloodborne viruses, reduce the risk of contamination. So there's an inbuilt filter system, so it also protects the needle, because as we all know, when people start to use them, when mix up their heroin, their citric, they like to stir it up, and sometimes you can tip the needle, which bloods the needle. So the filter protects against that. And also there's evidence to suggest that the needle itself is designed to reduce dead head space, so that if a person decides that they're reusing a needle, that there's less blood contained within it, so the risk of bloodborne virus transmission is reduced further. So at all times, currently this is the only type of pack and needle available through community pharmacy. It was decided, well, not decided, it's legislated for that pharmacists cannot manufacture packs on site. We need an INB license to do that. So this is why everything is nicely packed together. It took 3 years to get water for injection from a pharmacy-only product so they could hand it out without needing a prescription from a doctor. And so there's a lot of work gone into just this little pack. And the whole idea, as time has gone on, this is running about a year, and I know people in the audience have been involved from the very start. And we're coming to the end of our first year where we're looking at seeing what we need to change, and what's come back is the leaflet looks too complicated. Another issue coming back is some service users saying there's too many needles, too many one-hit kits in the pack, can you reduce it further? And also we're getting some further evidence of an increase in steroid users looking to access services. These needles, syringes, types are unsuitable for steroid users. And any time a steroid user presents to a community pharmacy, they're encouraged to refer that person to a static exchange or to the local outreach service in order to access that. The recording requirements are very simple. Why are they very simple? Because the first year we decided to start slowly. Of course, I love the NEO system in Scotland, and I got told I was running far too fast for my own good, and I had to take it easy until we had decided what we needed. So we look at male-female breakdown, we look at age, possible age group, number of exchanges, number of unique individuals, number of items returned, and then if they have a referral process. And then in our referral, we look at tier 3, tier 4, whether they're referring on to their local GP, who they know maybe prescribes methadone or an opioid replacement therapy, bloodborne viral testing to the local clinic or to the local services or to their GP, Hep B vaccination and others, which is a wonderful vague term for any other event that may occur other than these former three. The evaluation is currently underway, and I have some data at the end of this as to why, what's expected on the first visit. We're looking at maybe some of the collation of data that we need to look, and we'll have to go speak with data protection about how much data can we collect from a patient on their first or subsequent visits, like date of birth, initials. Currently we're looking at, just so it's easy to kind of decipher out unique individuals for the pharmacists at the end of each month, is to look at initials with a possible year of birth as a very vague identifier which cannot uniquely identify each individual. To ask questions like, is this your first visit? Are you using drugs? Have you previously engaged with the needle exchange program? Do you know how to use a one-hit kit? Some of our comments coming back from clients and service users who've used this have said that, I'm not sure how to use this kit. So we've gone back out to the pharmacists involved and gone through with them how to use the kit again, because the kit itself is quite specific in the sense that when you're drawing up into the barrel, there's quite a strong vacuum that sometimes you have to wet the filter before actually drawing through into the barrel itself. We might look at information about how far you travel into your local needle exchange. What would you prefer from this needle exchange service? Where would you see it? What it's trying to do is put pharmacies somewhere that they can signpost patients away from injecting drug use into a program, be it treatment, be it detoxification, attend to their local GP, and also to move on and out from active drug use. I guess this is fresh off the press, so it was done at 6 o'clock this morning, to be precise. So I was even late with the move. This is just showing as time went on, and also with this, obviously the numbers of pharmacists participating have been increasing, but as you see, the number of unique individuals attending for needle exchange is heading up to over 250 individual people, with obviously more male than female, which is not surprising. We've had a couple of cases where there's been 1 or 2 individuals coming in maybe every second day looking for needles and works and actually looking for more. And what we've done is try to encourage the pharmacist to ask, are they giving them to somebody else, a partner, another group of individuals that should be accessing this directly in order to refer them into service. The other number of packs provided, the total number of packs provided, as you see, is increasing as time has gone on. We're now using over 885 on April, which rose again, when I had a quick look through the MACE statistics, to about 950. Again, with the number of packs returned rising slightly as well, we're doing not so bad for a new program. I was expecting a very low return rate. We're getting about between 42 to 46% return rate, and which is slightly rising on each month, which is quite a positive affirmation that people who use these are quite knowledgeable about the fact that they need to return them. Not that they need to return them to get an exchange, but to return them for the safety of themselves and their communities. And just this is the total number of packs provided, which currently at the moment is about 3,000. The number of men looking for exchange is much higher, obviously, than women, which is commonly seen quite commonly throughout all statistics in Europe, versus the number of female exchanges. And a quick trawl, I did a very quick piece of work just to see about referral. Is referral happening? Because at the very start of this, I think pharmacists themselves were unsure about what they need to refer and how they should refer. So I looked at a very quick sampling of 177 different episodes of a patient looking for a needle exchange when they were referred. And as you see, that there is quite a huge referral, well, huge in the sense that it's up there at almost 25, up to 25% have been referred for treatment services or to go to the local addiction services, be that their GP or be that the statutory service or the voluntary service in their local community. And with those being referred for bloodborne viral testing and vaccine following behind.